All right. So talking about in general the management of type 2 diabetes, your first intervention is going to be lifestyle changes. Your first line therapy is going to be metformin. If at 3 months they're still not at goal, or even if on diagnosis their A1C is pretty high where you know one drug's not going to cut it, you could probably start 2 at that time, but you're going to be adding an agent. They will not make you, I don't think they would make you pick between a lot of these different agents for kind of the second add-on therapies. I think they're going to make you recognize based on patient characteristics which agents would not be best. Does that make sense? So really these are going to be kind of your next mainstays, the GLPs, the SGLT2s, the DPP4s, and if cost is an issue or the expense is a problem, that's when you would say, all right, let's look at the sulfonylureas or TZDs, because they really have more side effects, hypoglycemia, weight gain, but they're cheaper. So you want to add insulin early when the A1C is more than 10. Oh, who would prefer that? So maybe they're already on several agents and their A1C is not controlled. If you're worried that they have an autoimmune, right, type 1. If they are coming in with frank symptoms, right, symptoms of hyperglycemia, polyuria, polydipsia, again, in that setting, their A1C is probably going to be over 10 anyway. But if somebody really has overt signs, they should be on insulin. So a patient is on multiple agents, metformin, sulfonylurea, maybe another one, and their blood sugar is still high, their A1C is 9. What is your next step? Insulin. And then what are you going to do to their current meds? Stop the sulfonylurea, right, because that will increase their risk of hypoglycemia. The same patient does well on glargine or Lantus. You titrate them up. Their morning sugars have been less than 130. They're on the metformin. Their A1C is 8.5. What do you do? Check postprandial. Fabulous. Why? How come you don't titrate the insulin glargine anymore? Right, because they're at goal. So on the test, that's going to be the first step, right? You're going to be starting insulin. You're going to be slowly increasing it by a couple units every few days to get their morning fasting sugar at goal. This person's morning fasting sugar is at goal, but why are they still not controlled? You need to see what their postprandial levels are. A patient on metformin getting contrasted CT, what do you tell them to do? Hold the metformin for 48 hours. So this is a fun chart of biguanides, which are metformin, sulfonylureas, which are glipizide. All right, I'll pull this up so you can see both. TZDs, which are, right, Rosie, Pio, right, the glitazones. The DPP4s are your the SGLT2s are your flozins, and then the GLPs, right, are here. The tides. So for cost, which two are cheaper? Metformin, sulfonylureas, TZDs. Which one have risk factors, risks of hypoglycemia? Mm-hmm. So sulfonylureas and some TZD. Which one have issues with weight gain? No. Sacrilege. How dare you talk about metformin that way? Sulfonylureas, TZDs, I would star this one, right? Lots of risks of edema in your heart failure patients. And then put a happy face by the SGLT2s, right? Because they can actually cause weight loss. Plus a touch of dehydration with that. Some warnings or side effects with these, right? The metformin. Lactic acidosis. Long-term treatment-wise, what nutritional deficiency do you have to be mindful of? B12. The EGFR, right? Avoiding it with an EGFR less than 30. Sulfonylureas. Right, the biggest one's hypoglycemia, which is compounded by sometimes the half-life, right? So with glimepiride being the worst, and I remember that because or glimepiride and glyburide being the worst, because they are longer. So you want to be avoiding these in CKD and elderly. So renal insufficiency, right, can worsen the hypoglycemia. DPP4s and risk factors. Pancreatitis. What do you think a risk factor could be with slowed gastric emptying? Yeah, so if somebody has gastroparesis, this could potentially make their symptoms worse. And then the SGLT2s, UTIs, yeast infections. I'm not sure about Fournier's. Is Fournier's increased with SGLT2s? Yeah. What else? Dehydration, euglycemic DKA. So these patients need clear instructions about symptoms of DKA, that checking their blood sugar alone does not rule out DKA, right? They should not be reassured when they're having nausea, vomiting, belly pain by a normal blood sugar, right? They should be given urine ketone strips that they could check at home. Good. A patient on 70/30, maybe because of cost reasons, twice a day, has issues with nocturnal hypoglycemia. What do you recommend? Why do they have the hypoglycemia?
Is this like post-dinner?
Why do they have a nighttime low blood sugar? Right, it's from their nighttime, right? It's from the peak, right, of the NPH. The NPH is going to have more of a peak. And so ideally, how could you get rid of that?
Take it earlier.
Or if cost wasn't an issue, switch onto something that doesn't have that peak at the middle of the night, like Lantus. Same person, maybe their blood sugar before dinner is frequently 200. How do you adjust the regimen? Increase what? Their morning dose. A patient is on Lantus at night with a fasting blood sugar of 170. Postprandials are usually less than 180. What do you recommend? Increase the glargine, right? Their morning fasting is not at goal. What conditions can affect your hemoglobin A1C? Yes. Right? Things that will change the lifespan of that red blood cell. So if those red blood cells are getting destroyed quicker by hemolysis, or if they are getting replaced with a blood transfusion, that's going to make the A1C look artificially better than it is. If those red blood cells are hanging out in the body longer because they have to, because of issues in the bone marrow, kind of getting more red blood cells out there, then it might look worse than it is. Patient with diabetes, complicated by retinopathy, CAD, and strokes, has a couple episodes per month of hypoglycemia. Some he's asymptomatic with. His A1C is 6.2%. What do you recommend? Less stringent, right? Let it go a little bit. This is very risky for him, right? He's got evidence of really complicated disease, or in somebody who's elderly, your A1C goal is going to be closer to 8. DKA management. So starting with your fluids, right? Your first line management for DKA is going to be the fluids. You're going to be giving normal saline. When do you switch to half normal? When do you switch from your half normal saline to D5 half normal saline? This is when your sugar drops to less than 250, right? Because you want to keep your endo tool going, but you need to give them back some dextrose so they don't get low blood sugar. So when do you go from normal to half normal? When you have made them euvolemic, right? They're coming in very dry. You're going to give them a bunch of fluids in the beginning to hydrate them up. But then after that, if you keep the normal saline going, then they're going to get a non-gap metabolic acidosis. So switching them over after your initial hydration to half normal will help avoid that non-gap acidosis that's complicating your picture. So insulin, you're going to start with an IV bolus with the infusion. When do you add on the sub-Q insulin? When the gap is closed. Bicarbs are better, but be mindful that if you didn't do this, your bicarb could still be abnormal. So gap closed, ketones gone. When do you go from adding the sub-Q to doing just sub-Q and stopping your endo tool? A couple hours, yeah. Electrolytes, when your potassium is low, hold your insulin. So you need to replete the potassium first, right? Otherwise, giving insulin, that's one of our therapies that we give for hyperkalemia, is going to make this shift more into the cell and drop to an even criticaler range, right? So you hold the insulin, correct that potassium, keep going with your fluids, all right? Add more potassium to the fluids, and recheck before you start your insulin. Potassium of 5.2. All right, here you're pretty good, and you can not necessarily need to add in potassium up here with these fluids. And then you always want to evaluate for the trigger. Why did this person go into DKA? Do they have an infection, an MI? Are they doing drugs? Are they not on their regimen? A patient's being treated for DKA on an insulin drip develops difficulty breathing and muscle weakness. The most likely cause is low phosphorus. A patient on an insulin drip is being transferred out of the ICU. They were using 40 units per day. What would you transition them to? So what's kind of your general How would you choose? How much were you going to do basal? 20 units, right? So starting, kind of cutting that down and say, we'll give half of that as a basal, and then you're going to do, right, maybe 7 with meals. If somebody is in the ICU for a hot minute, this can be higher than it really is, right? If somebody is day 3 on the endo tool and this is your last 24 hours. The first day, they're going to be using a lot more. So that also is something to kind of keep in mind, that if this is 40 units for the day, or it would have been 40 units for the day and they were only there 12 hours, right, then this might be higher than what they really need. Does that make sense? But I don't think they would be too tricky like that on the exam. When do you recommend an annual eye exam in a newly diagnosed type 1 diabetic? In 5 years. Who gets one now? Type 2, because they've been rocking their diabetes probably for a little bit longer. So newly diagnosed type 1, you start their screenings, their eye exams, their screening proteinurias in 5 years. Type 2s started at diagnosis. A lean older patient develops diabetes. What tests could you check to see if it would be best to start with insulin in him? You could do a C-peptide. What else? A GAD, right? So you're looking for antibodies of an autoimmune cause for the diabetes. So GAD, glutamic acid decarboxylase, is most common and most tested. Other ones are islet cell antibodies and insulin antibodies. So switching to hypoglycemia, right? So somebody has symptoms of a low blood sugar. They say it gets better with eating. You're going to do a fast. If during the fast they don't have hypoglycemia, stop the evaluation, right? When you do the fast, if they get hypoglycemic, then you need to send off, right, your lab work to see why. The glucose, the insulin, the C-peptide. So doing those, right, you know that their blood sugar was low, you've documented it. You're going to then look at your insulin level. If your insulin level was low, right, so your glucose is low and your insulin level is low, what does that make you think? So let's start with this pathway. If your glucose is low, and then you look at your insulin, and you're like, this is weird. My insulin is high normal or high. You look at your C-peptide, right? Your C-peptide is low. So if you're, I always have to think about these things. So the insulin and the C-peptide should match, right? In a normal person, they should match, right? So if they match, what does that mean? It's from insulin in your body, right? There's insulin in your body that is being released. That's why your insulin is high and both your C-peptide's high, right? So why do you have that extra insulin? What could that be? An insulinoma or sulfonylurea, right? This is insulin coming from your body, right? You have these other things that were cleaved with the insulin. So this is from the pancreas, right? Where's the insulin from? The pancreas. Here, where's the insulin from? You only have high insulin and your C-peptide is not high. So your insulin is coming from a bottle in the Pyxis or from your partner. Right? So that is surreptitious insulin use, right? So now that you're at this category where you're saying there's insulin coming from the pancreas that's driving my low glucose, my next step is a sulfonylurea screen. And if that's negative,
Insulin.
you think it's an insulinoma. So your next step, if you think it's an insulinoma, is a CT. If the CT net is negative,
You do the
an endoscopic ultrasound, right? You have biochemical evidence. You know it's there. You have to prove it to the surgeons probably before they're going to go to surgery. That way they don't have to take out the whole pancreas. So you want to do an EUS to see if you can localize that sub 1 centimeter tumor that's not apparent on imaging, right? So for which of these is surreptitious sulfonylurea use?
Wait, what about the other one?
What if it's a mystery one?
Oh, so this is normal. So if somebody has low glucose, you would expect that their insulin level via feedback should go down.
Yeah. So they're just starving.
Possibly. Right, so if you're saying if you're checking and there's in starvation or in liver failure, probably.
What do I write down?
This, you right here, you expect this.
Okay, expected.
So if the insulin is not low, that's abnormal.
It's not okay for people to become hypoglycemic. That's not normal.
So they're on metformin.
That's not normal.
So you throw them on like a thiazide? I've done that before.
Your liver is supposed to kick in.
Yeah, that's
I'm
true.
on a D.
So you have to have some sort of...
Let me get back to you on that. I was trying to make this more helpful, and now I think I just confused myself.
You're working up hypoglycemia.
Right?
This isn't just a normal patient. Yeah, they don't have a good story.
Yeah, let me think about if there's other causes. Right, but then usually you have that clinical story, so you're not going to do the workup, right? But if you did the workup, that's what you would see. Yeah. All right. Reel it back in. We have 40 minutes. So which of these would you expect in surreptitious sulfonylurea use? So this is potentially a question format that could be on the test. So to answer these, I look at the one I know that's easiest, right? Kind of start excluding things. So let me look at the glucose first. My glucose will be low, so I can exclude A. I'm not going to look at A anymore. My insulin will be high, so that does not help me. So then I have to look at the C-peptide. So which of these C-peptides is surreptitious sulfonylurea use? All right, it's coming from your pancreas, so it's going to match your insulin. A patient has daily symptomatic hypoglycemia. He's not diabetic. He's having to wake up at night to drink soda during his fast. His sugar drops, C-peptide and insulin levels are elevated. Screen is negative. What's your next step? CT. If it's negative, your next step? EUS. An elderly diabetic patient has stroke-like symptoms. Check a blood sugar. All right. Let's breeze through thyroid really fast because it's so fun. Let's do it. Okay. So starting first with hyperthyroid. So remember that elderly patients can present with apathetic hyperthyroid. Just AFib, just heart failure, right? So keep that in mind, and that's why we check TSHs. Remember over here, when things look the opposite of what we expect with the TSH, remember to think about the pituitary, like we talked about yesterday. Your testing for hyperthyroidism is going to include the TSH screen, and then it's going to include free hormone levels. This is where you include T3, because you can have just an isolated T3 toxicosis. So if you looked at just TSH and just T4, you could diagnose somebody as subclinical when really they had an overt T3 toxicosis. This is the only time you need the T3. You're going to be using your radioactive iodine uptake scan to give you a better picture of what's going on. What patients cannot get that? Pregnant, breastfeeding. If there's diffuse increased uptake, that's Graves. One hot foci. Toxic nodule. Multiple hot foci. Toxic multinodular goiter. Suppressed gland. Exogenous or thyroiditis. It's just purging its hormones. So in terms of evaluation, look on the test for clues for Graves, right? You're going to see eye disease. That's Graves. A family history may clue you into Graves. Pretibial mixed edema is a clue for Graves. The antibody testing, do you really need those? No. But when would they be most helpful? They'd be most helpful up here when you can't get your uptake scan, right? If your patient's pregnant, breastfeeding. The treatment for each of these, right, Graves, a toxic nodule or goiter, thyroiditis, factitious, is going to be different, right? You have a few options. You have just symptom control. You have antithyroid medications like PTU and methimazole. You have ablation, and you have surgery. So for each of these, it's going to be picking what is the best option. For Graves, you can actually go into remission. This is an autoimmune condition. Medications like methimazole clears the antibodies that's causing the problem, and you can go into remission. If it is a toxic adenoma and you give them methimazole, is that going to get rid of that adenoma? No. So they're going to be on a medication for life, right? So in those cases, an ablation is kind of more preferred because you can ablate, it preferentially hits that hot nodule, and so actually the rest of the tissue doesn't get as ablated, so you don't have as much issues with post-ablation hypothyroidism. Right, so kind of choosing your treatment based on the cause of the thyroid condition. Looking at the side effects of PTU and methimazole, which one is most associated with liver issues, hepatotoxicity? PTU. Drug of choice for first trimester pregnancy. PTU. Drug rash, agranulocytosis, both. Mild cholestatic reversible liver injury. Methimazole. Aplasia cutis and choanal methimazole, right? So overall, methimazole is worse for the baby. And that's why during organogenesis we pick PTU. The PTU overall is less ideal for the mom in terms of risks of more significant liver injury. It's dosed multiple times per day. So after first trimester, you can switch back to methimazole. Yeah. The other one we should add here is thyroid storm. Which one has an added bonus? PTU blocks the peripheral conversion. So in the setting of thyroid storm, if you have both of those as options, picking PTU. But after the storm is fixed, transitioning to methimazole because it's better. Treatment for Graves in somebody who has Graves' eye disease. Which therapy can worsen the eye disease of Graves? Radioactive iodine uptake. A patient has a multinodular goiter and they undergo cardiac cath. They're now coming in with symptoms of hyperthyroidism. What happened? Iodine load. They probably had a pre-existing, right? Goiter, nodule that just needed iodine to light on fire. That what phenomenon is that? Jod-Basedow. So that's it for the questions for hyperthyroid.
So for 52, so you said that radioactive iodine worsens it, but the question says what's actual treatment choice?
So you can do medications. If it's very severe surgery, I guess I should say treatment to avoid.
Oh,
Treatment to avoid in Graves' eye disease. Thyroid storm, right? Finishing up with that. Remember treating with the 3 Ps, prednisone, propranolol, PTU, and looking at inciting events. So switching over now to hypothyroidism. Remember some clues that they'll give you on the exam. Delayed relaxation of the deep tendon reflex. That is a huge clue. You go like this, and it's slow to relax, right? Normal upshoot, slow to relax. Remember, central will be the opposite direction of the numbers that you would expect, but this is going to be the most common category here. So we're starting with the TSH, and then we're checking a free T4. No role for T3 over here. You want to see, is this subclinical, and do I need to treat it? Right? Is this a patient that could become pregnant? Is the TSH over 10, and they are most likely going to continue to progress? Do they have positive TPO antibodies? Those are the people that you would say, let's treat in this subclinical state, not an asymptomatic individual with a TSH of 5.5, right? You'd say, let's just follow. And then remember, central hypothyroidism, you are following treatment with free T4. So going back to some questions. How would you treat hypothyroidism in a middle-aged female that you've diagnosed with presumably Hashimoto's? Levothyroxine, weight-based, run-of-the-mill patient. And then you're going to be following TSH. How do you treat secondary hypothyroidism or central hypothyroidism? Levothyroxine, weight-based, following the free T4s. How would you treat subclinical? Right, so evaluate if you even need to treat. Right, do they have a goiter, TPO antibodies? Are they going to become pregnant or interested in becoming pregnant? Is their TSH more than 10? You see a patient in pre-op clinic. They're going to get a knee replacement in 1 week. or tomorrow, as it is here in TGH Pre-Op Clinic. Their TSH is 40, they have mild fatigue. What do you do? That's the question. Can they go to surgery or not? Yes. This, right, start levothyroxine, but this is less risky than somebody who is maybe on the hyperthyroid side going to surgery. That one you would say, let's pump the brakes on this elective surgery. A patient who's elderly, history of CAD or arrhythmias. Low dose levothyroxine, right? Not weight-based. Somebody who's currently on levothyroxine now comes in and she's pregnant.
Increase 30%.
Increase automatically. All right, you're going to be increasing 30 to 50%, and you're going to be following her TSH how often?
Every 6 weeks.
Every month, right? Because if you do it every like 8 weeks, that's like hardly any follow-up during the pregnancy, right? So every month. So young patient wants to be pregnant, goiter, TSH is 7, TPO is positive. Treat. Elderly man, fatigue, TSH is 7, free T4 is normal, no goiter, no antibodies. Follow, right? This is subclinical, TSH under 10, even with the fatigue. I have fatigue. Everybody has fatigue. What's fatigue? Exactly. Let's look for the testosterone deficiency. Hypertensive patient, you find a thyroid nodule. It comes back as medullary cancer. The calcitonin levels are elevated, which is going to be your tumor marker that you're following pre and post treatment. What's your next step? Yes! You did not fall into my trap. The trap was send them for resection. When you need to say, wait, this is medullary cancer, they're hypertensive, do they also have a FEO? I need to work that up first before going to surgery for this. Young patient with a thyroid nodule, TSH is normal, 2 centimeters. The biopsy shows follicular neoplasm. Next step. All right, so that is, oops, this down here. So thyroid nodule, first thing you do is see if it's hyperactive. If it's a hot nodule, you do not biopsy. If you're euthyroid, then you need ultrasound. So if you see this nodule on a PET scan, if you see this nodule on a CT, if you see this nodule on a physical exam, you still need the ultrasound to better characterize size, cystic or not, microcalcifications, all of that. So pretty much, I think on the boards for you guys, remembering 1 centimeter is the size that you're biopsying, right? So this one was 2, which is why they went to biopsy. And then what do you do with that result? So most of them will be benign. You can follow. If it's non-diagnostic, you repeat. If it's malignant, send them to surgery. If it's follicular, you need the capsule. There's newer stuff coming out there about like oncotype testing on it to see if you can determine if it's higher risk for malignancy. I don't think they would ask you that on the test. So the answer was you need to resect it to determine if it's benign or malignant. You need the whole capsule to evaluate. So the most sensitive test for thyroid function in a patient with an intact pituitary. TSH. A patient has hyperthyroid symptom. Oh, where did I skip one? The test used to follow up and assess for recurrence in papillary or follicular thyroid cancer. Thyroglobulin. That is the cells that hold and store thyroid hormone. So that should go to 0 after ablation. You're ablating all of that thyroid tissue. A patient with hyperthyroid symptoms a low TSH and a normal T4. Next test, T3. All right, you would say, oh, this looks like subclinical. You need to rule out an isolated T3 toxicosis. This is associated with increased risk of developing overt hypothyroidism, TPO. Most reliable test as you're titrating your medications in Graves' disease. These are going to be your free hormone levels, right? So your free T4, if it was the T3, the TSH can still be affected by the antibodies in Graves'. The lab that can help differentiate factitious from thyroiditis in a patient who's hyperthyroid with low activity on their uptake scan. Right? You think they're kind of sketchy, but they're not fessing up to taking it. You're like, I think it's that and not thyroiditis. What lab could you look at? Thyroglobulin. In fictitious, what is your thyroglobulin level going to do? Be low, right? This is the cells that store thyroid hormone. If you are taking thyroid hormone, do those cells need to store thyroid hormone? No, right? So that's going to be low. In a patient with panhypopit on levothyroxine, what do you measure to adjust their dose? Free T4. I think I've asked this 20 times, so if you miss this on the test, I'll cry. A tumor marker associated with medullary thyroid cancer, calcitonin. If you were to order a test, which you would not do on the boards because you are practicing high-value care, but if you were to order a test to confirm sick euthyroid, it would be the reverse T3. But you can clinically call that without that lab test and say, just follow up and recheck them in a couple months. What symptoms would you say, let's do surgery in a patient who has a multinodular goiter? Stridor, dysphagia, right? So symptoms of compression. Star question 60. Highlight star. Suspect this condition in a patient with long-standing Hashimoto's with rapid increased swelling of their goiter over the last month. Lymphoma, yes. A primary thyroid lymphoma. The long-standing Hashimoto's is a risk factor, and the presentation is going to be a rapidly expanding goiter. How do you diagnose? Biopsy. Tissue is the issue. So tissue is the issue, and then you can treat the meat. A first trimester pregnant patient presents with symptoms of hyperthyroidism. The TSH is undetectable. Hormone levels are high. TPO and thyroid stimulating immunoglobulin are elevated. All right, you suspect Graves, you would start PTU since it's first trimester. And methimazole can cause baby problems. Pneumonia, ICU patient, TSH is low, T4 is kind of low. Do you think they have central hypothyroidism? No. You think they have sick euthyroid, and you say, recheck. Do nothing now. Most likely cause of primary hypothyroidism. Hashimoto's. Patient presenting with mixed edema coma. How do you treat? Steroids first. Beautiful. Right? Because you can have both hypothyroid with adrenal insufficiency. So steroids first. Levothyroxine. Warm them up. Give them fluids. right? They're hypotensive and altered and all of that, so you're going to be probably doing empiric antibiotics, cultures. A thyroid nodule is on PET, ultrasound. Preferred treatment for a toxic adenoma. Your options are medical therapy, surgery, ablation. Ablation, I would say surgery is a close second. Meds are third. Meds are last. Follow-up that's needed after ablation for hyperthyroidism. All right, you want to follow them for hypothyroidism. Let's keep going with this since I hear, I think, some rumorings out there. The most common tumor associated with hypercalcemia and PTHRP. Squamous. All right, so it's squishy and cavitary calcium. Put that together with squamous. SCC, squamous cell cancer. Cavitates and calcium. I like it. And it's squishy. And it's central. The postmenopausal female has osteoporosis and achalasia. How would you treat her osteoporosis? Correct. Avoid oral bisphosphonate given her achalasia. A patient with multiple myeloma is treated with IV Zometa. Now has pain in her molar region at the site of a prior dental extraction. What happened? Osteonecrosis of the jaw, right? So this is something important to get a dental screening for those that we don't need to start this emergently. And then for those that are on this frequently, they need to know and be aware to instruct their dentists about this. Patient with HIV has sepsis and miliary TB. The calcium is 10. The phos is 4. The albumin is 2. What is happening?
Vitamin D from the brain.
So we're saying that the calcium is high. Why is this calcium high? Right, so you have to correct for the albumin. Correcting for the albumin makes this calcium, right, so say 0.8 for every 1, right, so at least 1.6, right, so at least almost 12. And so why are they hypercalcemic? We're saying they have miliary TB, so I think it's from this vitamin D production from the TB. So what labs would you check next? What's your next lab test after confirming hypercalcemia? Say with an ionized calcium, PTH. The PTH we expect in this person to be low, right? That is not what's driving their calcium. Something else is driving their calcium. So the PTH steps back in response and can like snooze a little bit. So the PTH is going to be low. And we think it's from this TB, so our next test is going to be, which one is it? 25 or 125? 125. When you have extra calcium, add that extra number, 125. When your calcium is low and you're screening for vitamin D deficiency, you need less numbers, so just the 25. Right? Postmenopausal female with osteoporosis on her DEXA. Her calcium is low. Her phos is okay. Her PTH is high. What is your next step? What does she have? She has hyperpara. Which hyperpara? Primary, secondary, or tertiary? Secondary, right? Because the calcium is low. So your PTH is high in response to your calcium being low, and it's not driving it. So it's secondary. What causes secondary hyperparathyroidism? Vitamin D deficiency, right? And she's got osteoporosis, so let's screen and rule out vitamin D deficiency. The other big one is CKD, which we see her creatinine's normal. Fastest acting agent to give in hypercalcemia, calcitonin, but the first thing you're giving in hypercalcemia, fluids. What is your vitamin D of choice to supplement patients with hypoparathyroidism? So this is coming back to this slide. All right, so looking at PTH, so this is somebody who has hypoparathyroidism, so maybe it was resected along with their thyroid or what have you. So PTH affects the bone, PTH goes to the kidney, right? PTH comes over here to cause vitamin D to be transferred to its active form, the 125 vitamin D. So if you don't have PTH from hypoparathyroidism, what vitamin D should patients get? The 125, right? That's going to be the best vitamin D for them to get, which is calcitriol. Mild hypercalcemia. In clinic, asymptomatic, what should you be thinking about? Don't read the next line. Oh. First thing, right? Hypercalcemia in the hospital, you think malignancy. Hypercalcemia in the clinic, you should think primary hyperpara, right? Things with primary hyperpara that can look similar on labs is going to be familial conditions, right? So you have this person who has a brother who has also had issues with his calcium. You check a PTH, it's high normal or inappropriately high normal. So what do you do next? Send for parathyroidectomy or check urine studies? Check urine studies, and you're looking for what on the urine studies? Low calcium, because the condition is familial hypocalciuric hypercalcemia. So just seeing and reading the name of that condition will tell you what to look for on the test. It's familial, there's low calcium in the urine, high calcium in the blood, usually asymptomatic, do not have symptoms from the calcium, no stones, no problem, they don't need treatment, right? Whereas, what would be a situation where somebody could have primary hyperpara with a familial issues with calcium? MEN, right? It's an MEN1 and MEN2A, right? So just because you see other people in the family having issues, don't automatically assume this is going to be FHH. Take a look at their calcium. 40-year-old patient, hypercalcemic, calcium's 12, PTH is high, history of stones. Next step. All right, you would probably make sure that there's not a combined vitamin D deficiency, probably get some urine tests, but overall you think that this is primary hyperpara. And when do you send them for surgery? This is the Ocean's pneumonic. So calcium, more than 1, the upper limit of normal. What else?
That's just EGFR.
EGFR.
Osteoporosis.
Then I heard this one. Symptoms or stones. Age. Cutoff is 50. Do you have to be older than 50 or younger than 50 for the surgery? Younger, right? You're going to have this adenoma forever. It's not going to go away. So if you're 80, rock it out. If you're 30, that would be painful, right? So age, less than 50, send them to surgery. N is they're not going to follow up. So they don't want to come in and get their labs checked every year and get DEXAs and all of that. Right? Make sense?
What is the
Osteoporosis, calcium 1, the upper limit of normal, right? So usually around 11.5. EGFR less than 60, or you can remember elevated creatinine, age under 50, not going to follow up, or they're having symptoms. Any of those, anyone, send them to surgery. If they give you the option of surgery or sestamibi scan, surgery. Sestamibi is really just for the surgeons and their surgical planning. You are not using that in your diagnosis and kind of clinical assessment. Most common side effect of Zometa. Yeah, bone pain, flu-like symptoms. Which of the following labs would you expect with milk alkali syndrome? So start with the calcium. Would you expect the calcium to be up or down? Up, right? So you get rid of D. Would you expect your PTH to be up or down? Down, right? This is not being driven by the parathyroid. It's being driven by the buttload of Tums that they're taking. So you get rid of B, right? So you're left with A and C. So then you go over to the FOS. Is their FOS going to be up or down? Down. All right, so this is going to be more excess vitamin D. When do you obtain a screening DEXA in a patient on chronic steroids or that may be on chronic steroids? 3 months. If they're on 3 months of steroids, get a baseline DEXA. This one I don't think they would ask you. This is a hereditary condition. This is pseudo hypoparathyroidism or McCune-Albright PTH resistance. I don't think they would ask you that. Which of the following do you expect to see in vitamin D deficiency? So start with the calcium.
Low.
Low, that's not helpful. Then go to the PTH. High, right? Your PTH is responding to the low calcium and saying, I need more calcium. I'm going to increase my PTH to pull calcium from the bones, keep it in the kidneys, to activate my vitamin D. So then is your FOS going to be high or low? Low. Right, so looking at FOS, so with vitamin D, both calcium and FOS are being pulled from the gut. Okay? So your calcium and your FOS are going to be mirrored in vitamin D issues. All right? In kidney issues, right, your calcium and FOS are going to be opposite. Right? We did the men syndromes yesterday. A patient is following up labs for evaluation of hypercalcemia. Calcium is high, FOS is low, vitamin D is low, PTH is high. What is happening? So the calcium is high. Your next test was going to be a PTH. You see your PTH, and your PTH is very high. That suggests that the PTH is driving the hypercalcemia. So they have primary hyperpara, What do you make of this? If they had vitamin D deficiency, what would their PTH be? High. But what would their calcium be? Low, right? So you are calling this not vitamin D deficiency, driving everything, because that does not explain the calcium. This is all from vitamin D. The calcium should be low. This is somebody who has primary hyperpara and a vitamin D deficiency. So you'd give them vitamin D, right, and still send them to surgery. Classic finding on the hand x-rays in somebody who has primary hyperpara, subperiosteal bone resorption. You can also see brown tumors. Okay. Let's fly through these answers too. So PCOS, you have issues with amenorrhea or oligomenorrhea, infertility, insulin resistance, hyperandrogenism. Note that ovarian cysts are not part of the clinical picture. You can have PCOS without having ovarian cysts on an ultrasound. How would you manage their hirsutism? You can do spironolactone. You could do OCPs. You should not be doing spironolactone without OCPs, right? Because you're then going to help this lady fix her infertility, and then she get pregnant, and spironolactone and pregnancy is no good. How would you treat the insulin resistance? Metformin is off-label, but yes, diet, exercise. How would you treat the menstrual irregularities? OCPs. But if she wants to get pregnant, that is not helpful. So then you could do clomiphene, letrozole, lenastrozole. Metformin, again, is not FDA technically approved. So amenorrhea with hirsutism, amenorrhea with hirsutism and virilization, right, should make you think of different things. What two things over here that are bad would you think of when you see somebody coming in with amenorrhea with virilization, right? Hirsutism, male pattern balding, deepening of the voice, clitoromegaly. They are having a lot, right, over here. This is androgen excess. This is super androgen excess. Which two androgens are potentially in excess? DHEA, which is coming from the adrenal gland. Whoa. Zona reticularis, yes. Where else are you getting androgens? Testosterone. From where? Ovaries. So those are your two bad things that will make you sad over here when you're evaluating this patient for amenorrhea. Otherwise, your first test for amenorrhea is going to be a pregnancy test, right? That'd be so easy. Oh, you're pregnant. Done. Your next test is going to be an FSH and LH, right? That will help you figure out, is the problem in my ovary or is the problem not in my ovary, right? If you're having amenorrhea and your FSH is high, it is saying to the ovary, pick up the pace. What are you doing, right? You can see my little drawing here. Oh, the ovary's bad. Oh, feedback. Oh, FSH. So what could be going on in the ovary causing amenorrhea? If this is primary amenorrhea, she's never had a period in her life, you should think about Turners, and you should get a karyotype. If this is secondary amenorrhea, right? So she's had periods before, and now she hasn't had periods. What things in the ovary could cause that?
Agelessness.
Right? Why would she have that? What would make the ovary go and cause ovarian failure? What causes premature ovarian failure?
Hypothalamus.
Mm-mm.
No.
Right, her thalamus is fine. Look, her FSH is kicking it. We're right here. We're here in the ovary.
We're in the ovary.
So this you should think about in patients who have autoimmune issues. They have vitiligo, they have Hashimoto's, they have autoimmune alopecia. Now they have amenorrhea. You should be thinking, ooh, this is somebody who has polyglandular autoimmune syndrome. I'm worried that this is autoimmune failure, right? Other causes of failure, somebody who's had chemotherapy, right?
Oh, not ovarian.
Stay in the ovary. Right? So now moving out of the ovary, right? Your FSH is low. So the problem is coming up top. So it could be hypothalamus or it could be pituitary. And we've talked about some things, right? What is a hypothalamic condition? That can also be associated with anosmia, calmness. What if this was a marathon runner or a lady with an eating disorder?
Just like low. I don't know what the
Functional hypogonadotropic hypogonadism, right? This is more hypothalamic, right? Pituitary causes are all of the things that we talked about before causing hypopit, right? Resection, radiation, a pituitary tumor causing mass effect, bleeding into the gland, infarction of the gland, right? Anything else that can cause pituitary issues. Other things, right? So we're always screening also prolactin, TSH. What other things cause amenorrhea with hirsutism? PCOS. What else? Congenital adrenal hyperplasia, although rare.
But it could still happen.
I'm not knocking it down. It belongs in the box. You keep it in the box.
What about like testosterone?
And
Or exposure. I just see prescribed it.
presumably, yes. Cushing's, right? Cushing's is going to be our other one, especially Cushing's disease, where you have that increased ACTH, increasing your DHEA, but it's not to the extreme over here as it is with those tumors within the glands. First step in evaluation of infertility.
What?
Sperm count. That poor lady, Phil. You're just rubbing salt on the wound. Yep, you're right. You're not pregnant. The medication that can be used for PCOS to decrease
What's the first count?
sperm.
Why do we assume?
It's a simple test. Goes simple, easy. It's probably from all the pot that little boy's doing, you know. Medication used for PCOS that can decrease androgen levels, improve insulin resistance, increase pregnancy rates. Metformin, although not really FDA approved. A young patient has secondary amenorrhea, no past medical history, medications, family history. Your first test, which is your pregnancy test, is negative. You check prolactin, FSH, TSH, free T4, which are normal. This should be next step.
Check the estrogen.
How could you check her estrogen?
Give them like the challenge.
Yes. So you want to give a progesterone challenge because that will tell you if her body is producing estrogen, right? So you give a challenge of progesterone and you look for withdrawal bleeding, right? What do you make of this?
So it's like it's an organ problem.
It's an organ problem.
It's been a long day. The uterus. I was saying it's a primary use of uterus.
So having amenorrhea and having a normal FSH, right? You need to think, is this appropriate or inappropriate, right? So when you do your progesterone challenge, if she doesn't bleed, right, which means her estrogen stores are low, is her FSH appropriate to be normal? It's inappropriate to be normal. Her FSH should be what? High. Her FSH not being high tells you that the problem is up here, right? This is so tricky, right? You really don't be fooled by normal levels. You have to think about the feedback loops and if that is what you expect it to be, right? Because if her body estrogen stores are low, right? You give her progesterone, she does not withdraw bleed, that equals low estrogen. You look at her labs, her FSH is normal. If her body is not making estrogen, her FSH should be high, right? So the problem's not in the ovary, because if the problem is in the ovary, her FSH should be super high. So the problem is outside of the ovary, the problem is up here, and that is where you need to look next. Is it endocrinology so amazing? That's it. 403.
Wait, there's a
Where's it at? I mean, there's hypogonadism.
Oh, well, we really don't care about that. Right? Let's do this really quick.
It's our fault.
Oh, that's so funny. I didn't plan that at all. So men who have symptoms of hypogonadism, right? Decreased libido, fatigue, muscle, lean mass decreased, whatever those symptoms that men think are from low testosterone. You are going to screen them and BT dubs. If it's normal, you don't treat. You do not give them testosterone, even if they keep asking for it with a normal testosterone level. So you're checking an AM total testosterone, right? So if they give you on the test a testosterone that's drawn in the afternoon, that's abnormal, repeat it in the morning. If they give you a testosterone, and think of testosterone like B12. So B12 right? So it's the same thing. Less than 200 of these, deficient. More than 400 of both of these, normal. This middle part, gray zone. Right? So for B12, you could check MMA, right? For testosterone, you could check a free testosterone level, right? So you're going to confirm it. You're going to make sure it's at 8 a.m. If it's kind of borderline, still check a free testosterone level, right? Because we're going to hold on to this testosterone and make sure they really need it. And then you are going to be doing all of this workup to see why they're testosterone deficient, right? With your FSH and LH driving the path. So you have low testosterone that you've confirmed and documented. If the FSH and LH is low, right? The testosterone is low because the FSH and LH are low. So it's coming from up here, right? Whereas if the testosterone is low, right, then the FSH and LH should be high, right? So that is a testicular problem, right? FSH and LH from the pituitary are saying, I need more testosterone, but the actual, but the primary source is not making it, right? So what causes testicular problems with testosterone? Infiltrative diseases are tricky. They can cause both. What else? Treatment of cancers, right? So they had chemotherapy for their Hodgkin's. They have had trauma to the testes, torsion, mumps. What else? Klinefelter's is Klinefelter's is, let me go. Yeah, it's just like Turner's, right? So you have atrophic testes on exam, so that's going to be a clue for Klinefelter's. And then you would have the feedback loop going back up, right? And then going back to this, hypothalamic pituitary, similar things as ladies, right? Kalman's, functional causes like medications, OSA, right? Untreated OSA, hemochromatosis, right? So infiltrative diseases, all of these things. Know the side effects of treatment, right? So you are following hematocrit, right? It can cause polycythemia. You're following the PSA. If you're having a rapid increase in your PSA, you're gonna have to stop therapy, do DREs, make sure they're not having prostatic hypertrophy. So couple presents for an infertility eval. The man has decreased libido, arthritis of the hands, low testosterone, that fits the bill, at 8 a.m., low LH and FSH, that tells you the problem is where? Right? Up top. Mildly increased AST and ALT, normal prolactin and TSH. What does he have? Hemochromatosis. So you're going to check transferrin saturation. If they have both on there, a ferritin and a transferrin saturation, pick the transferrin saturation because it's not an acute phase reactant. So they're going to give you somebody who is very simple and not everything like this of hemochromatosis. They're going to give you just the hypogonadotrophic hypogonadism and arthritis of the second and third MCP, or pre-diabetes, or, right, they're not going to give you everything and tell you he's got diabetes and he's bronze and he's got joint pain and all of that stuff. They'll pick one. Patient's coming in for low libido. He's obese, normal testes volume, no gynecomastia, Testosterone is 210 at 4 p.m., so gray zone. What do? Get a morning total testosterone level. A patient on testosterone therapy, PSA recheck was 2. His baseline 6 months ago was 0.5. Your next step? Stop. DRE. And refer for biopsy. Patient is referred for ED with a normalish testosterone level. What can help you determine psychogenic erectile dysfunction versus organic erectile dysfunction? Great job. Some may call that nocturnal penile tumescence. If that is not happening, that suggests an organic problem, vascular neuropathic. No, thank you guys.